morning, good afternoon, and good evening, everyone, wherever you may be. Thank you for joining us for today's session. And the session is about establishing a socially just response to COVID-19 from the vantage point of urban informal settlements. And the presentation will cover a program. It's based on a RISE project, and the work is going to be presented from multiple um, settings. We have Bangladesh, we have India, Sierra Leone, and Kenyan setting. And I'll be your moderator today. My name is Dr. Lilian Otiso. I'm the Executive Director at LVCT Health, and I'm part of the ARISE consortium that is presenting this work for you today, focusing on the work we've done in informal urban settlements and looking at the partnerships and multi-sectoral action to respond to COVID-19, as well as methods for co-production and change. Next slide. So to start off, I just want to give you tips on using the platform so that you don't struggle and you're able to go through it. Well, there's a live support button at the top or a tab at the top of your screen. If you have any technical challenges, the HSR team will be at hand to support you with that. And then we have a live Q&A session. How the program is structured today is we have 5 presentations in total, 3 to start, followed by a Q&A session. So we would like you to keep asking questions as we go along. Some will be responded to on the chat, and we hope to have some that are responded to live during the session. So after the 3 presentations, we'll have question and answer responses. And then we have the last 2 presentations followed by a Q&A and then summary of the whole session. And we hope to finish within the 75 minutes allocated. For best user experience, please use the full screen function, and then the sessions will be recorded and will be available for 14 days post the conference. Also, you can see there how to adjust your browser. Please adjust your browser zoom ratio to 67% and play the session in full screen to get the best out of this session. Next slide. So we will start with our presenter from India, and that's JK Lakshmi. But just to also give you a sense of overall, what we hope to achieve from this session is to explain the drivers of vulnerability prior to and during this pandemic and describe the role of the state in mediating vulnerability and resilience. Then we want to analyze how all this has happened and how we've created vulnerability and the role of communities in mitigating this, as well as looking at sharing some results that have come through from the ARISE project that we have done. So our first presenter is JK Lakshmi. She's from the Georgia Institute for Global Health in India, and she will be taking us through, she is a senior research associate. She has a bachelor's degree in homeopathic medicine and surgery, and she has a PhD in health promotion and disease prevention. And you can see her research interests covered there. And today she's going to take us through a session focusing on the particularly marginalized group within urban informal settlement in India of the waste pickers and how they are particularly vulnerable and how they've been vulnerable during this COVID phase. So welcome, JK. Over to you. Thank you.
Thank you. Can we move to the slide, please? Yeah, I will present some findings from a case study of experiences in the pandemic among marginalized communities of waste pickers in India and make the case for the understanding of diversity and the need for non-uniform support customized to people's needs. Next slide, please. We conducted interviews on the phone with waste pickers in the informal sector and some waste pickers on contracts with the local urban government in Vijayawada, Guntur, and Bangalore, 3 cities in South India. This method, necessitated by the restrictions in the pandemic, straightaway meant that the most marginalized communities were left out of our interviews because they may not have been familiar with our civil society partners through whom we got in touch with our interviewees, and they may have had no phone or phone charging facilities. So with that disclaimer, we move on to the next slide. Disadvantaged communities face hardships in accessing information, livelihood, relief in times of need, healthcare, and overall well-being. Please click again. Yeah, with the pandemic, with its threats to health and the movement and entry restrictions implemented, are superimposed on these pre-existing privations, compounding, exacerbating, and amplifying the distress of people, as exemplified by this statement that an interviewee made. Please click again. So this is from one of our interviews. We are crying about our fate, unable to die, unable to live. And that is in the local language Telugu, chavaleka bratakaleka, which means unable to die, unable to live. We move to the, yeah. The pandemic has prompted aid of a few kinds from the government, from NGOs, and from private philanthropists. But there are several lacunae in the aid that people could access and use. In the first place, not all in need were reached. And please click. And those reached found that aid was in some cases not comprehensive, that is, all aspects of their need were not addressed, and in many cases not adequate, that is, insufficient for their requirement. So please click again. Certain categories of foodstuff were provided, some personal protective equipment, some household essentials, not others, and some healthcare was available, but no support was available for access to that healthcare. There was little to no support for menstrual hygiene management, and nutrition and stay, which was made available to some persons in the community, some students in the community, was denied them during the pandemic. In terms of adequacy, the quantum of food and household essentials was not always sufficient for the households. We'll go to the next slide, please. So accessing aid in pre-COVID as well as COVID times is predicated on certificates of citizenship, by which I mean documents like the Aadhaar card, ration card for subsidized foodstuff, PAN card for employment, and so on. Please click again. Here are some of the cards that we need in India to get by. But simply having these documents in one's name does not ensure access, a problem felt acutely by migrant workers and homeless persons. Please click again. Here we have a quote from a person who was a little vehement here because Indians have just gone through an exercise in documenting citizenship and they're really troubled by this exercise. So he says, "We are Indians. I have all the documents like you have," and you in this case is the interviewer. And he lists a few documents that he has. But although he has a ration card, he does not get ration since the ration cards are based at their homes. This is a migrant worker. And when they move from their homes, those ration cards don't work elsewhere in the country. So he's still not able to get subsidized food. The next slide, please. Over the next few slides, I have quotes from interviews that illustrate the lacunae in aid and the experiences that I've just spoken of. And so each of these slides brings together some quotes. This one brings together quotes on support from the government. So we did not get any help from the government. Only the NGO gave. The government says rupees 1,000, which works out to about $13 US dollars for each family, but we did not receive it. We are still waiting for financial assistance. Then one interviewee said, they said that only those who have ration cards will get the 1,000 rupees. But in this community, only 2, 3 families have ration cards. We have applied several times for ration cards, but we haven't got them and we don't have any information on them. So getting documentation is very difficult. And my children used to stay in the government hostel and study, and their meals were assured there. Now that schools have closed, that is for the pandemic, and they're at home, we are struggling to provide them adequate food. And then there's something that is pre-existing. I mean, not a COVID brought about situation, but before. Our biggest need is houses. Women are facing many problems. They don't even have toilets, and they have to go in deserted open areas. It's difficult to have a wash in private, and no place to wash and dry the cloth we use during menstrual periods. We move to the next slide. The other pathways to relief, non-government pathways to relief. Uh, on the top, you see that there's some happiness and gratitude. We got rice, we got lentils, we got tea leaves, whatever is required for the house, we got it all. We are really happy. We never thought someone would help us. But still, there is a problem. There's water shortage, no cooking gas, and difficulty cooking. And another quote, each rupee matters now for a person. Just lentils and rice alone, which is what the bulk of aid is, won't run the house, will they? And if somebody falls ill at home or if some problems arise, it will be a huge issue. And then this is an epidemic, so to save ourselves, we need to stay at home. But if we have to stay at home, there should be support for the poor. If you look at the model in India where people are running here and there and not receiving what they should receive, how will one live in this situation? Next slide, please. And then food was given to people by governments, by NGOs, and by private entities. But there were problems that people faced in the quantity, quality, and familiarity of food. So we received rice and dry provisions thrice during the lockdown, but that was not adequate. We were eating one meal a day for many days. And they received only rice and dal, no oil, salt, sugar, soap, or anything else needed at home. People gave us some food, but it was not suitable for small children. So there were members in the household who were not catered to. They gave us sambar rice. So that is a well-known dish in South India, but it was not fully cooked. And they gave us whole Bengal gram ones. What can we do with that? So some people are unfamiliar with certain items of food. Next slide, please. The police interactions with the police were mostly troubled interactions. We have downloaded the Arogya Setu app, which is an app propagated by the government for information and uh, prevention of the infection during the pandemic. The government is saying that the app will be like an e-pass. If you go somewhere and you do not have a pass, the police will leave you alone. We are unable to go to hospitals for health problems because we don't have money to consult doctors. If we come outside for work, we are beaten by the police in our area because we are from a red zone, which is a zone which has many cases, pandemic cases. And when we tried to resume work after the lockdown, we were troubled by the police. They said, we give you rations and all that. Why do you need to get out? But the rations are not much. If the NGO had not helped us, we don't know what we would have done. We would have died of starvation before Corona hit us. And individual philanthropists sometimes provided a lot of aid. They gave us cooked food 3 times a day for 15 days. But after a few days, the police came and told us not to take any cooked food, take only dry provisions. And from then on, our problems have begun. Next slide, please. So this is interactions with in the community during the pandemic. We're talking here of waste pickers who come from marginalized communities. So what they say is people are hostile to us. They do not let us collect water from the hand pump in their area. They used to shoo us away because of our caste and because we pick waste. So caste and occupation were the bases. Now they are also worried that we may spread the disease. People are scared to employ us when they know that our area is a red zone. So even when they are able to get out of their zone and look for jobs, they don't get jobs. Next slide, please. Healthcare access, some of these examples are pre-COVID and non-COVID healthcare access. Before the lockdown, the medical team came here for malaria checkup and gave us some tablets and injections. But since the pandemic began, there is no support for malaria control. My daughter is undergoing treatment for TB. The doctor came out of the hospital during the pandemic restrictions to hand over the medicines to me. But I had to spend a lot to reach the hospital using a share auto, which is an intermediate kind of public transport whose rates went up sharply in the lockdown. Most of the time, people visit government hospitals, but they also have corona patients. So we prefer to get our medicines from private hospitals, which involves expenditure. And this is a long quote. What it means is the money that they get is just about enough to survive. But the youngest daughter needs medical care in addition. So they spend a minimum of 1,000 rupees a month on her medical care, and their parents also stay with them, and the parents have medical bills too, so they need to take loans in order to manage. The next slide, please. So the principal recommendations that arise from this case study is that policy and provision need to be based on principles of equity and diversity, taking intersectionality into account to be just, and not based on uniformity. And these some recommendations from this case study are that we could make all government documents valid nationwide so that people can move about freely in the country and still be able to avail themselves of the benefits, and assess disadvantaged communities in getting government documents, make policies sensitive to migrant workers, please click again, and have a holistic view of support for health and well-being, keeping intersectionality in focus rather than narrow foci on particular foods or fixed amounts of subsidy. Finally, it is clear that the government cannot provide all the solutions needed by people, and the contributions of civil society organizations and private philanthropy are vital. So government policies need to facilitate these entities in order to supplement their own efforts. Thank you.
Okay, thank you very much, JK, for setting the ball rolling. Thank you for your very interesting presentation and hearing about waste pickers and what they have gone through with COVID. So for all the people, the attendees, please just put your questions in the Q&A section, and then we'll be able to respond to them as we go along in the presentation. And the panelists will be able to answer them and have sessions to interact further. So next we have Sabina Rashid. She's from the JPG School of Public Health at Brack University, and where she leads two centers of excellence at the School of Public Health. the Center for Gender, Sexual, Reproductive Health and Rights, and the Center for Urban Equity and Health. She's a renowned social science researcher with specialization in ethnographic and qualitative research. And she's a part of the ARISE team. And today she'll be presenting on fault lines in public health and the COVID-19 response, experiences from Dhaka, Bangladesh, where they have large informal settlements. Welcome, Sabina.
Sorry, I'm trying to figure out technology and I'm not good at it. Thanks for the very generous introduction. Haven't been called renowned in a long time or ever. So thanks, Lillian, for saying that. I'm going to try and stick to between the 7 minutes allotted. But really, today I'm here to share from a research project that my colleagues and I in Bangladesh, and working closely with partners, are based on the COVID pandemic, which is still going on in Bangladesh, but trying to understand its initial impact when it hit sort of the global pandemic stage, but different countries experienced it differently. And Bangladesh went into shutdown mode from the last week of March till about June. And the impact on really the informal residents living in these settlements, which Dhaka houses millions. And Dhaka actually has the largest numbers of informal settlements or slums, or whatever we prefer to call them. So I'd like to request the person to go to the next slide. Thank you. So it's predicted by 2040, so that's 20 years from now, over 50% of our Bangladesh's population will live in urban areas. This is a picture of, I mean, the rapid sort of mushrooming of settlements where you have it even along the railway tracks. And, there's a higher growth in informal settlements. There's a push and pull. Please don't change slides till I ask you, if you don't mind. I don't know who's managing the slides, but thank you very much. Yeah. And there's a higher growth in informal slum settlements. Thank you. Next, please. The lives of urban slum by nature is there isn't an official comprehensive urban policy. There's an unofficial policy, which means the lives, whether they live in private land or government land, is essentially insecure. The jobs are informal, daily wages, erratic jobs, usually not a lot of savings and debt, threats of eviction, you can be removed at any point, even though there's a Supreme Court ruling that you cannot evict and they need rehabilitation. The reality between the law and implementation, there's a gap. NGOs are very active, but government per se has little investment in slums. And the people who live in these settlements have high-risk occupations. Next slide, please. So Dhaka capital, I mean, this is where I reside. There's about 7 million people living in the informal settlements. This is a guesstimate. And most of them, as I said earlier, informal workers, could be rickshaw pullers, could be daily wage earners, domestic help. But just to give you a sense, 70% are working in the informal sector. So you can imagine when COVID happened and there was a complete shutdown of education, businesses, industries, garment factories, there was no income, there was no work. And government declared it as a holiday, which created a lot of confusion. And there was police and army on the streets to enforce it. So many settlements, many of our areas, wherever you lived in Dhaka city, but throughout the country, had complete lockdown. There was also mass confusion. People had holiday, people kept hearing about a virus. Everyone's globally connected, be it TV or mobile phones. And many also went back to the villages. Next slide, please. So we've been doing a series of rapid assessments at the Brack School of Public Health, James P. Grant, about 32 assessments that continue. This was one of the particular ones that we undertook in early, sort of late March till about May. And we interviewed sort of majority of females, most are Muslims. The average age was 35. They've been residing in the settlements for more than 20 years, some since birth. This was their home. And the household size ranged from single, when we say single, it could be 5, to even extended families of 11. Usually, if you were slightly better off, you could share 2 room spaces and adjacent to each other. But the bottom line is it's very congested, very crowded, and basic services tend to be low. Next slide, please. So context matters. The reason why I say this is very important to have a social science perspective is that when we started doing our phone interviews, and we got ethical clearances, there was a lot of confusion around what's a cough and a cold and what's coronavirus. And the language of quarantine and isolation and red flags initially were being placed in households that had corona patients turned it into a lot of fear around death, disease, and stigma. And there was also fears about people being picked up, being isolated, and then they would not get the appropriate religious burial. So a lot of confusion, a lot of misinformation. And you have to remember, in the Bangladesh context, like many countries, it was a clinician-led task force. So the virus and prevention was very biomedical. Next slide, please. So there was internalized fears like surveillance of others, underreporting, so people were not sharing with community health workers or pharmacists or others. There's harassment of, we had case studies of families being asked to leave because their husband had come back from Italy, they were seen as the carriers, or they had a cough and a cold, there was harassment. Of course, the stigma is greatly reduced now, but at that time, it was really, really a huge challenge. As a woman said, she had a fever, she went to a local pharmacy, rumors began, the pharmacy said, please don't come near me, you're infected. So it was extremely rampant. And you had media messaging of dead bodies, isolation, quarantine, red flags. This was March, April. So it was basically crazy. This was happening even in the richer areas where people were putting locks outside houses of rich suburbs because people were sort of stigmatizing and absolutely really, really scared of who was the carrier. Next slide. So one thing that's really important to understand in these contexts, unlike the better off, is they share communal spaces. So when you have these messages of maintain social distancing, wash your hands, don't be in overcrowded spaces, most of the respondents, 31, shared communal toilets and bathing spaces. They shared water supply. They collected drinking water from congested queues. They tried to manage, even the cooking was in congested spaces. So the reality was they couldn't always manage the reality, the national guidelines from WHO, wherever, being pushed on them. Next slide, please. So, I'm going to quickly share this, that they said, how do we manage this? A mask is 30 taka. That's the price of some food. Remember, these people have no income. Jobs have stopped. They're informal workers. Then buying soap is 60 taka. $1 is 80 taka, but that's a lot of money. That might be a bit of rice and egg for a family, for individuals. And they said it's very impossible. Some manage to rotate their hours, but the reality is informal settlements have poor infrastructure, poor services. So the ground reality didn't match the sort of COVID biomedical messages they were getting. And there was a lot of sort of fears and a lot of blaming. Next slide. A majority lost their income, 41 of the 51. But if you look at it, many studies were coming out at that point in Bangladesh where 50 million livelihoods were affected. There was cancellation of orders by garment buyers in the West. 1.3 billion pounds were lost, which means workers were not being paid and factories were affected and some factories were shutting down. Almost all of the women, because of mainly women we spoke to, talked about emotional and mental anxiety and stress. They're worried about, increased arguments and who's going to feed the family. Men worried about what's going to happen, how they're going to support the family. And they talked about rationing food to support their children or elders. Next slide. I'm towards the end. So final point is that, we look at COVID and we look at it as a virus, but it really has an impact on people's lives, their personal, their social, their economic, their political. And it all comes together. So if we want to understand health, we really need to understand the experiences of COVID for the most vulnerable. Here they talked about disrupted networks of support. Loan sharks were out. Neighbors that they'd known for 10, 15 years couldn't lend them money, not because they didn't want to, but everyone was vulnerable. They were relying on community and family members, NGOs, BRAC and other organizations were actively, but how much can you do when you're 50 million affected? There were relief materials. The government rolled out various national stimulus packages, but there was a lot of controversy around mismanagement and politicization of it. In general, there was also fear of crime, and people were desperately looking for work. So they would defy the police and get out on the streets. So final points are that I'd really like to share. Next slide, please. Thank you. That we need to address the situation of the urban poor, but really it's about the most vulnerable. And we need to look at context, because context matter. You cannot have some universal COVID guideline and then apply it, different contexts matter. Even within Bangladesh, rural and urban spaces matter. Let's not homogenize the poor. They're not a box, they're not numbers, they're human beings. We just have the privileges, they don't. I think it's important to desegregate data by gender, age, occupation, ethnicity, because intersectionality matters. And we need this kind of information to prepare for not only this COVID, but also future pandemic outbreaks. And I think it's very important to invest in longitudinal qualitative research, case studies. My final 2 points are, we really need to unpack health beyond a biomedical disease model. We need to talk beyond epidemiologists and statisticians who are important, but social scientists and social science that can really give you the complexity of these pictures and help design programs and interventions as well. We need a socially just model. So thank you very much. And as I said, NGOs and others are trying and they're working and they've been very, very proactive. But I wanted to give you the picture of a small group of people, but as data shows, many have been affected by COVID. Thank you. We've opened up. Bangladesh has opened up. It's no longer in shutdown. The poor are back to work. Yeah. Thank you.
Thank you very much, Sabina. That was an inspiring presentation, and thank you for bringing the reality to that aspect of looking at socially just models and making it people-centered. So we can't have one size fits all, which was seen in a lot of settings in this response. So thank you for that presentation. We appreciate it. Next, we'll move on to Joseph McCarthy. And as we do, again, I'd like to encourage the participants, please post your questions and comments, any thoughts or reflections, or any additional thoughts you may have to discuss on this issue of the socially just response to COVID among the informal urban settlement dwellers. So Joseph is from Sierra Leone. He is from the Sierra Leone Urban Research Center, and his presentation will focus on the City of Freetown's response to the COVID-19 outbreak, outlining deficiencies wrought by an approach that does not respond to the specificity of urban informal settlements. So he's here, thank you. He has authored, he currently co-investigates 3 projects on urban health with SLAC, and is jointly implementing with some other partners in Freetown. He has also authored a number of research articles. So welcome, Joseph. We look forward to your session, to your presentation.
Oh, Jesus Christ.
Hi, we can't see your video. Are you having any technical issues?
Hello, everyone. I am Joseph McCarthy, the Executive Director of the Sierra Leone Urban Research Center. I'll have to join my colleagues to do a presentation on the side of Freetown, Sierra Leone. When the COVID-19 outbreak struck, it exposed the state of weakened health system in the country. But what struck out most was what exactly happens to the most unequal people when the government chooses to adopt a one-size-fits-all response to pandemic, and more especially to people living in informal settlement. In Freetown, Sierra Leone, 35% of the people live in informal settlements. These are places generally characterized as having poor housing conditions, places with acute environmental conditions, especially in sanitary conditions, places that are overcrowded. They are generally settlements that exist on at-risk settlements and therefore become worsened during health epidemics. They generally exhibit greater spatial inequalities, especially in terms of the provision of services and infrastructure. When the outbreak struck the country, the key response measures by the government were generally limited to public health responses, and these were in the form of social distancing and hygiene promotion. But what these measures really did not do was to take into consideration the implications that the measures will have for the poor and vulnerable people living in these settlements. For instance, social distancing adopted two measures, lockdown and curfew. When you choose to lock down people, and especially in the case of the 3 lockdowns that we experience, it supposes that people, especially living everywhere in the city, have stockpile of food and water to take, especially when staying home. Curfew also gives the impression that people generally have a place to stay, especially when you impose a curfew from 9 p.m. to 6 a.m. It gives the impression that even the poor have a place to live. And even some people who had a place, it will interest you to see about 7 of 9 family members living in just one room. So those are the kind of experiences. Also, in terms of public hygiene promotion, there was the insistence on washing of hands, and this gives the impression that almost all homes have access to water, easy access to water, especially to be able to do this. There was also the requirement for people to wear face mask, and this also supposes that everyone has what it takes to be able to purchase it. But then this is a photo of one of the informal settlements in Freetown, where during the lockdown, when people were expected to stay at home, they had to congest around a water point because they never had water in their homes. And also you can see that there is no observance of social distancing rule. Basically, what the measures had, the effect that these measures had on vulnerable and marginalized people was that generally, because people were required to stay at home, they were not a chance to go and do their normal trades. And so therefore, a lot of them lost jobs, especially those who were into petty trades and even those who were in the entertainment industry. And so therefore, their livelihood support was almost cut off. And for most of these people, their livelihood are generally directly linked to the informal economy. We are talking here about people like petty traders, especially those who work at night. And so therefore, a lot of homes were faced with hunger. Some could not even afford food because most of them live hand to mouth. They cannot afford food beyond a day. And so therefore, stockpiling of food or stocking of food was a very serious challenge. We also had a number of these settlements that were challenged, especially in terms of having access to water. You can see from the photo that was previously shown. And also for women, this was so much of a burden, especially those who take care of their homes, who are responsible for the financial burden of their home. More especially because the men and women now had to live for more hours at home. Issues of domestic violence was very much prominent among women. And also because of the kinds of messages, public health messages that were sent out initially, some people were scared of visiting health centers for fear of not being suspected of showing symptoms related to COVID-19. Additional to the public health measures, the government, especially this local council, provided basic facilities such as buckets for hand washing, but also soap and water to some of the communities. A few households were provided with food items, and some who contracted the disease or their relatives were provided with psychosocial support. But then what all of these measures means is that there was a kind of top-down relationship between health authorities or the government and the informal settlement dwellers. And so therefore, the measures did not meet so much the aspiration of the people. And therefore, over time, the response by the government has generally been rated as being fairly impressive. So because the community residents were not so much satisfied or comfortable with the response from the government, a lot of them organized themselves, they pool resources together to provide support for those homes that are more vulnerable and marginalized, especially during the lockdown on curfew. They provided support in the form of food. They used the resources to buy food or to buy water, which they distributed among their peers, especially those who could not afford. They were also very instrumental, especially in sensitizing, but also disseminating information, especially about COVID, especially in terms of providing messages in the kinds of languages and in the mediums that their colleagues can better relate with. And they also self-organized, especially to enforce some of these COVID measures in their communities, especially to avoid overcrowding. They were also very supportive to the Freetown City Council and to some NGOs, especially the City Council undertook what they refer to as the community kitchen, which was so much about providing food support to the residents within these communities, the marginalized residents within these communities. But then they did not even have proper data in terms of who were these particular people. So they had to rely on the community groups to be able to do that. So the key lessons from this particular discussion is that local realities in informal settlements are not generally the same as those across the city. And even whilst we continue to ignore informal settlements, there exists some level of agency which can be harnessed, especially in response to health emergencies. And we therefore argue that incorporating local communities in the response makes the process a lot targeted, effective, and efficient. Thank you very much for listening.
Okay, thank you very much, Joseph, and thank you for also flagging what's going on in Sierra Leone. And the context sounds very similar to what we had earlier in terms of the vulnerability and how the groups are not homogeneous and how we have to consider the needs of the different groups, as well as how communities themselves are quite useful in the response and working closely with government. So thank you for that. We have two more presentations to go. I can see that time is running out. So what we'll do is continue with the remaining two presentations, which will also be responding to some of the questions that are coming through, especially on methodology and research methods that are being conducted. So we can keep taking on the questions that are coming through and then have the final session dedicated to responding to the Q&A. So over to you, Beata. So Beata Ringwald is a PhD candidate at the Liverpool School of Tropical Medicine, currently working at LVCT Health, conducting her PhD. She has over 10 years experience working with youth, women, and communities in both Germany and Uganda, and currently doing her PhD within the Kenyan context in an informal urban settlement, looking at intimate partner violence and HIV intersection within this setting. So today she'll be able to talk to us about using methods for co-production and change and looking at violence in the informal urban settlements in Nairobi. Welcome, Beata.
Thank you very much, Lillian. Good morning, good afternoon, and good evening everywhere. I'm Beata Ringwald. I'm a PhD candidate with the Liverpool School of Tropical Medicine based at LVCT Health Kenya. Can we please have the next slide? I'm conducting in Nairobi a participatory study on community-based prevention of intimate partner violence and HIV in Korogosho, an informal settlement in Kenya. Both HIV and intimate partner violence are reported to be affected by the COVID-19 pandemic. My presentation today, I will focus on research methods for co-production and change. Building relationships is the foundation of participatory research. For my studies, these relationships include those with program partners at LVCT Health, with research partners, local authorities, service providers, and community members and organizations. The COVID-19 pandemic made networking more difficult, but not impossible. We adjusted our protocol and observed infection control guidelines. We could not hold an entry meeting, but we now engage partners bilaterally. In August, we formed a research team, 8 community co-researchers and 3 researchers. Since then, we have been able to meet areas. Community researchers appreciated to learn about the purpose of research and the steps in the research process. We took Sorry, my internet dropped. We took time to develop a shared understanding of the problem and the context that shapes it. We asked community co-researchers how they define intimate partner violence in their context. We used visual methods to describe the social relationships of women and men in the community of Korogosho, and we identified relationships that co-researchers considered intimate relationships and those relationships with violence. Next slide, please.
Good morning, good afternoon, and good evening. I'm Beate Ringwald, a PhD candidate at the Liverpool School of Tropical Medicine, and I'm based at LVCT Health, Kenya in Nairobi. I'm conducting a participatory study on community-based prevention of HIV and intimate partner violence in Korogosho, Kenya. Both HIV and intimate partner violence are reported to be affected by COVID-19 pandemic. The focus of my presentation will be on the research methods for co-production and change. Building relationships is the foundation of participatory research. For my study, these include relationships with program partners at LVCT Health, research partners, local authorities, service providers, and community partners. The COVID-19 pandemic made networking more difficult, but not impossible. We could not hold an entry meeting with community stakeholders, but now engage them bilaterally. We adjusted the protocol and observe infection control guidelines. In August, we formed a research team with 8 community co-researchers and 3 researchers. Since then, we have been meeting regularly every week. We invested time in building the research team, and we trained community co-researchers. We learned that community members are frequently involved in research as informants and data collectors. However, they rarely get a chance to be involved in planning of a study and often do not learn about the findings or results of studies conducted in their area. Community co-researchers appreciated to learn about the purpose of research and the research process. We also took time to develop a shared understanding of the problem and the context that shapes it. We asked community co-researchers how they define intimate partner violence in their context. We used visual methods to describe social relationships of men and women living in the study area, and we identified those relationships with a risk of violence. Together, we generated a definition of intimate partner violence that is relevant to the context, although it is broader than the standard definition. Our working definition is understood by everyone working on the study. Those involved in the local response to COVID-19 in Korogosho identified most vulnerable people in the community. You can find a blog about this on the ARISE website. We did the same as a research team. We assessed vulnerability to HIV and intimate partner violence and the level of involvement in community activities among different social groups in the community. From this exercise, co-researchers were able to select participants for the upcoming focus groups. Our next steps are to hold focus groups where we again work with visual methods to capture and document information on drivers of HIV and intimate partner violence. And we will also assess the impact that COVID-19 pandemic had on HIV and intimate partner violence risk. Community co-researchers will facilitate the focus groups and be involved in data analysis. I would like to end with a summary of the benefits of participatory research approach and the use of visual methods. Participatory visual methods helped us to build a team. Participatory visual methods are inclusive and accessible to those with and without formal education. Visual methods facilitate communication and discussion. Participatory visual methods helped us to facilitate co-learning among co-researchers and researchers. Thank you very much for listening.
Okay, thank you very much, Beata. Thank you for talking to us about participatory visual methods and how they're useful for the community. And that starts to respond to the issues that have come up about if you're looking for solutions at that community level, how you have to involve the community members as co-researchers and people who find solutions for what is affecting them. And it's quite useful now in this context of COVID. So next, and the final presenter for today, we have Caroline Kabaria from the African Population and Health Research Center. And she's a postdoctoral research scientist with expertise in GIS, remote sensing, and spatial modeling. So she holds a PhD in spatial epidemiology from the Open University, UK. And the research is focused on mapping and understanding changing malaria transmission. But today she'll be talking to us about exploring the data, vulnerability, and marginalization in Nairobi's informal settlements and how that has been useful for the COVID response. So over to you, Caroline. Thank you.
Thanks, Lillian, and thanks to everybody else who's presented before me. As Lillian has introduced me, Caroline Kabaria. I work at the African Population Health Research Center based out of Nairobi here in Kenya. And I'm going to be presenting on exploring the data, and this is looking at pre-COVID and during COVID trends, and these looking at vulnerability and marginalization in Nairobi informal settlements. I'm doing this presentation on behalf of myself and Professor Blessing Beru, the co-investigator at our center. Next slide, please. All right, so as a way of background is that historically a lot of health programming has been targeted at rural areas. And this has always been based on the assumption that urban populations are better off than rural populations. And thus, we've always had a binary classification of programming or even data collection between urban and rural areas. But as our work has shown through the Nairobi cross-sectional slum survey, that sometimes the pockets of urban poor are sometimes worse than rural communities. And as a way of example, there's a table on your right-hand side, which compares child mortality rates as a way of example, between data collected nationally through the Kenya Demographic Health Surveillance System and compares what has been collected through a cross-sectional slum survey. And as you can see, just looking at child mortality, the rates are quite low within the city at 17%, that is Nairobi, and nationally 15% in urban areas. But from the cross-sectional survey, you see that the child mortality is quite high, 40%. Same to under 5 mortality. Looking at vaccination rates, for example, you can see that they have high coverage nationally at 83%, quite close to that in Nairobi at 81%, but still low below 50% within the cross-sectional slum surveys. And this lack of a disaggregation of data to show slum population has always left slums not covered. So what I'm calling the hidden numbers. And it would be important to a lot of the decision makers to know what the data looks like in the slums. And this is what I'll be presenting on. Next slide. So I'm going to be presenting some work we've been doing in Korogocho and Viwandani, which is part of the 3 sites that are being done. We are going to be working in under the Arise Hub. This is Korogocho, Viwandani, and Mathare. So Korogocho has an average of about 10,000 households, Viwandani around 23,000 households. And this work is being done as a partnership between APHRC, LVCT Health, and SDI Kenya. Next slide, please. So as a way of background and the context is that these two, the study areas we've worked in are characterized by overcrowding, poor garbage disposal, poor drainage. Majority of the households, and this is data from 2018, from the Nairobi Urban Demographic Surveillance System that we run within the 2 sites, Korogocho and Viwandani. And you can see majority of the residents rely on buying water from public taps. Majority of them have what would be classified as unsafe sanitation, sharing either pit latrines or the ventilated toilets. Of course, the roofing material, most of it is semi-permanent, floor materials also being semi-permanent. And as Joseph was discussing earlier, that a lot of the COVID-19 measures relied on hand washing, isolation, and just looking at this context, I mean, social distancing. So if you're living in an overcrowded settlement, if you have to buy water, how often can you really wash your hands? If you're supposed to self-isolate in an overcrowded area, do those public health intervention measures really work? Next slide, please. So over the period between July and August this year, we collected some data in Nairobi in the two slums, which is Korogocho and Viwandani. And I want to be able to present how COVID-19 was seen as a driver of marginality. And I will compare this with data that we had before and what we observed during this period. Next slide. So this was done the data was collected through a qualitative approach using focus group discussions. And this was done in both communities, Korogocho and Viwandani, across different age groups and divided by gender. We spoke to village elders, persons living with disabilities, different groups of workers like sanitation workers, garbage collectors. We spoke to refugees, commercial sex workers. We also spoke to community health volunteers and parents with children, both adolescents and under fives. Next slide, please. So COVID-19 was seen to exacerbate the effect of marginalization, and three main areas were identified. So the first one being the loss of livelihood. So what you're seeing on the left-hand side is data that we have before of these two settlements. As you can see, that majority of the residents rely on casual employment, and some are also economically inactive. And what this means is the restrictions that were put in during the COVID-19 period, which is the restriction of movement and curfews, really had a huge impact on this population because for many of them, staying at home meant losing their jobs, while me and you could have the luxury of attending this conference by sitting in our houses. Majority of residents living in these informal settlements are not able to work while working from home, which means most of them lost their jobs. And as an excerpt is given there from one of the FGDs in Korogocho, you can say that women are hardest hit by COVID-19 because they are primary caregivers of individuals who are ill during the COVID-19 period. And women sometimes are not decision makers in most families, and as such, even the money they find in a day-to-day activity ends up in the hands of men in the family. So that's just a way of example. So that's one way that the community said they were impacted. Next slide. So the second way was disrupted access to healthcare. Again, I do a comparison of data before pre-COVID and during the COVID period. So just looking at an example of immunization services. So this shows Korogocho and shows immunization rates. So this is DPT3 on the left-hand side, and the next one is measles coverage. And showing that at sub-county level, which is the second level of administration, it shows, for example, DPT coverage is very high in the sub-county of Ruaraka at around 86%. But if you look within Korogocho itself, you can see that the immunization rates are all before 40%. So this was before COVID, and that means that already access to services was already low within the communities you are talking about. Looking at measles, the same case where you have the average of Ruaraka sub-county showing a high coverage of 77%, but rates within the slum are all below 20%. So these were inequities that already existed before COVID. But what happened during the COVID period is that then people who were already vulnerable became even more marginalized. So here is an excerpt from the FGDs talking about how access to healthcare affected a lot of mother and child health services. So some health services were compromised during the COVID-19 pandemic, services like mother and child services, even clinics. There are many defaulters as mothers fear visiting health facilities. And at the same time, referral facilities were also overburdened during the outbreak, hindering access to services. So again, emphasis on the fear that was raised, fear raised during the COVID pandemic, where people are afraid of attending health services, meaning that they are unable to access services. And at the same time, referral facilities are also overburdened. A different group of people who are have not presented here who are affected were people with chronic illness. So lack of income, again, compounded with lack of access, then would mean that a lot of people with chronic illnesses like diabetes are not able to access the drugs that they need. Next slide, please. So finally, the third theme that emerged from looking at the work, and this is was about lack of appropriate messaging for the COVID-19. So as speakers before me have spoken, that Kenya, the public health message was about isolation, wearing a mask, washing your hands. But a lot of the groups within the informal settlements, and maybe this may not be unique just to the informal settlements, emphasized that there was not appropriate messaging. So looking at children, a lot of children are not able to understand why they should wear masks, and they were not a focus group of population where they do not even have avenues to express the kind of anxieties they have. Persons with living disabilities were easily isolated in access to information, because some of, for example, for those who are hearing and visually impaired, were not able to understand a lot of the messaging that was being given, which of course limits their ability to conform with the measures that were being issued. Elderly people, of course, who also had difficulty accessing healthcare. Most of them required to be accompanied to health facilities, which of course poses the risk of getting infected, or at least the fear of getting infected by going to the facility. Of course, a lot of elderly people in these communities are also illiterate and were not able to interpret the COVID-19 messaging. So this is information that was coming from the two settlements that we were working in. And in the next slide, then we can get to discuss, think about then what are the policy implications. So this sort of circles back to where I started about the lack of disaggregated data and how this can impact how vulnerable population will either miss out on interventions or how they'll be further marginalized. So just saying that there's a need for disaggregated data that is slum focused, there's need to continue investing in slum specific data system, because urban programming, particularly in Kenya, which we have devolved governments to counties, is done at the local level. So if you have no data, and if your data is too generalized, then you're not able to identify where pockets of this vulnerable population are. I think the last message, which is a take home, is that a lot of these inequities already existed pre-COVID, but COVID made them worse. And again, saying that if you don't know where the vulnerable people are, then it's easy to miss them out. With that, I'd like to come to the end of my presentation and of course, acknowledge my partners in Kenya, which is LVCT and SBI, and of course the ARISE partnership. Thank you.
Okay, thank you very much, Caroline, and thank you for bringing us to the end of the presentations, and also just reiterating the same key message that has come through, the vulnerability among the informal urban settlement dwellers, and how COVID has just come to exacerbate what there was, and the issues of the lack of disaggregated data, and the need for us to find that, to make sure that that data is available to inform interventions that come. And it's very interesting that across all the contexts we've had from the 4 countries, the message is the same. First, the informal urban settlement dwellers are not a homogeneous group, and there are very, very many people who are vulnerable and in different ways. And that need for an intersectional lens and looking at what are the gaps and the needs even before COVID is critical, and it would have helped us to respond more effectively to COVID. But the main thing is, what have we learned from that and what can we take forward? So we have just 8 minutes left to the end of the session. So what we'd like to do is respond to some of the questions that have come through from the participants, and so that they can be able to answer the key ones that have come. So I'd like to invite Lakshmi, JK, to respond to the question on, there's a comment that came through from Godlive. Lakshmi and Sabine, great presentations and stark reminders of the realities of COVID response for so many people around the world. Question, since you both stress the importance of localized, not one size fits all responses, and removing ourselves from them, the two dominant biomedical models of dealing with the pandemic, how would this translate to the work of multilateral guidance agencies such as the WHO and of national political bodies in practice? Thanks.
Yeah, thank you, Lillian. I'll go first. So guidance agencies such as the WHO could, first of all, commission research and compile evidence and strategies to develop guidelines that are sensitive to the strengths and needs of particular groups of people and particular places. So context-specific guidelines. Further, I mean, no matter how much you tailor, and when you finally have to implement these guidelines, we need rapid evaluations to ensure that people are actually able to use the amenities, aid, and facilities, the support provided, and for nuances that may have been missed or unidentified in the guidance documents. Further, we need to, I mean, guidance agencies can insist on documentation of barriers, enablers, process solutions, and disseminate best practices so that people in other contexts can use these lessons. And most of all, I think that an organization like the WHO should emphasize the message that health is not exclusively about addressing disease, and that preventing disease and promoting health needs a very holistic view of all the many determinants of health. So like Sabina will now say, we need to pay more attention to the other determinants of health and not just deal with diseases with a band-aid approach. Thank you.
Thank you, JK. That's quite helpful and comprehensive. Sabina, as you respond, could you please also add to and respond to a question that came up on how, are there any particular challenges, in fact, in terms of conducting rapid qualitative assessment in a COVID context, assuming it was completely remote, any peculiar challenges as compared to regular qualitative research processes?
So I gave, I'm unmuted, I always forget. Thanks, Lillian. I actually gave my responses in the chat about the earlier comment that JK responded to. So I'm just going to quickly go into qualitative because of time. I think we did a bunch of rapid assessments. We are a research institute. What it is that we feed in directly into NGOs and key stakeholders. So while there was criticism by academics and certain bodies about what does rapid assessment mean, we had to continue to do research to feed back into BRAC, the NGO programs, other stakeholders. So we started our work. We have an ethical review board at the school. It was established in 2006. Very clear. I'll tell you a couple of things very quickly. One thing, we'd never done phone interviews. We've always done field work. So it was a very different mode of learning and training. And you have to pay attention to trying out questions, rethinking questions, calling back, a couple of times to understand, because you can't see the person. You can't figure out through expressions. On the other hand, because it was a complete shutdown, people wanted to talk. Because we've done 32, assessment, people wanted the mental, the hunger, the pandemic. We didn't anticipate trauma, and our researchers needed counseling. So we had to bring in online colleagues who work on emotional mental health support to also give support to our researchers, because they were hearing very, very difficult stories and they were having a hard time. Another thing is the ethics of doing phone interviews, taking up people's time, is we had money we paid, because in Bangladesh, most people have a phone, and we gave a certain amount of money for their time, because they would be otherwise, in this case, they were sitting at home, but they'd be otherwise working. I think trust is very important. We had access in areas that the NGO was working in. That made it easier. In some communities, we've been working there for a while, but it is not easy to do phone interviews, and we have to recognize when we're analyzing data, there's certain limitations to what it can share, but it can actually capture communities' own inputs on what's happening in real time on the ground. Right now, it's much harder to do phone interviews because it's opened up and people are working. But I thought, there's certain topics we stayed away from, like, violence, where we can't give referrals, it's on the phone. You have to be very, very careful. But overall, phone interviews were not as difficult as we thought, but you need to do follow-up interviews. You have to also work around timings of respondents. You have to make sure that you're sensitive to the family members around. I would say that would be some of our learning over time, if that's helpful. Thank you.
Thank you very much.
And feeding in over time, feeding in to NGOs.
Thank you very much, Sabina. And thank you to all the presenters. Just because of lack of time, we won't be able to respond to the other questions that have come through, but we'll respond on the chat. I hope we can still see them after this so that people can see in terms of their questions specific for data collection in Kenya, how can we collect data more efficiently, given the huge populations in these areas? And that was to Caroline, so we will respond to that. And she'll also provide the sources of the statistics that she was showing. Do you collect them through FGD as well? So those will be responded to specifically, and you can even email. I think we'll have those contacts shared later. But so in summary, what I'd like to say is that what we've seen is that we have same issues across different contexts before and even during COVID. So data on who is vulnerable is missing across board, and that was a challenge for the governments to respond. But what has come through is that the communities were really key resources. They were the people who came up with responses and were able to adapt even the guidelines that were coming through. So government recognizing the role of the communities in their own response is critical, and also working with multi-sectoral partners. So it's not just a government-led response, but we have community members, we have well-wishers, NGOs, CBOs, and even private sector really coming on board to support that. The aspect of being able to collect data, it's critical even during times like COVID, and finding innovative ways of doing it, like Sabina has just been talking about, and making sure that that data is disaggregated by gender, age, who's marginalized, and just applying an intersectionality lens so we can be able to inform responses. COVID is just one example. What we always talked about are our communities resilient. It's shown that they are, but there has to be a lot that is done to make sure that even in future, if there are such cases that happen, they'll be able to, will be ready, the data will be available, and the response will be guided by the needs of the community and avoiding the one size fits all. And also remembering to make sure that we take a social lens, socially just models, and not just biomedical. So thank you everyone for joining us today. It was a pleasure hosting you and having this session. We look forward to engaging more on the rest of this conference. Over.
Thank you so much, Lillian. Thank you to all the speakers. We'll see you around. Bye. Thank you.
Okay, bye.